Okay. So good afternoon, everyone. I'm Dr. Sorry, I will just show my video. Okay, so good afternoon, everyone. I am Dr. Luis. I am presently a second year network fellow at National Kidney and Transplant Institute. So today I will be sharing our case. This is a case of an encapsulating peritoneal sclerosis seen at NKTI last year. So this is my topic outline and my objectives. So we are presenting with patient BD, a 53-year-old female Filipino from Las Piñas City, Metro Manila. She is a diagnosed case of ESRD secondary to chronic glomerulonephritis, clinically diagnosed, and is maintained on CAPD since 2015. Her current PD prescription is for exchanges with 1.5 and 2.5% PDS solution alternating with a fill volume of 2 liters in a dwell time of 6 hours. Her usual UF is negative 500 per day with a residual renal function of less than 1 liter per day. For her past medical history, she is non-diabetic, she is non-asthmatic, and no history of cardiovascular events. She has some secondary hypertension. For the social and environmental history, she is a non-smoker and a non-alcoholic beverage drinker. Her family history is unremarkable, no history of hypertension, diabetes, kidney disease, or cancer in the family. So for the timeline of illness, the patient had her first PD peritonitis episode in 2017, presenting with abdominal pain, cloudy dialysate, and a positive drain. The cultures turned out to be a Staph aureus PD peritonitis, which was sensitive to vancomycin, and patient was given vancomycin for 21 days, which showed clinical improvement. However, in 2023, January of 2023, she had again episodes of abdominal pain with cloudy dialysate and positive drain. And this time, the culture revealed Pseudomonas aeruginosa, and she was given culture-guided meropenem and amikacin for 21 days with initial clinical improvement. However, in February 13, 2023, there was note of recurrence of the abdominal pain and cloudy dialysate and an increase in WBC of the dialysate CS of 8,062 with neutrophilic predominance of 97, and again culture revealed Pseudomonas aeruginosa, thus was advised for PD catheter removal and completion of the antibiotics for 21 days. She was then shifted to temporary HD. However, in February 2024, patient had episodes of missed hemodialysis due to financial constraints, thus presented at the ER with mild respiratory distress, grade 1 bipedal edema with some direct tenderness in the periumbilical area and dry previous exit site and no signs of infection in the previous PD catheter site. Thus, patient was optimized and was reinserted with PD catheter last March 13, 2023. This was already after her completion of the previously given antibiotics. However, just 3 days after the insertion of the new catheter, patient had again episode of cloudy dialysate and abdominal pain with WBC in the dialysate of 133, and this time it's a lymphocytic predominance, but culture revealed Acinetobacter with sensitive to meropenem, ceftast, and ciprofloxacin, and patient was given another bout of meropenem for 21 days, for which this was continued. However, on March 2025, there was already note of improvement and the repeat culture showed no growth with dialysate CCDC with WBC of 0. On April 6, however, this was 49 days after the PD catheter removal, the initial PD catheter removal, there was note of recurrence of the abdominal pain, but this time it was noted to have bloody dialysate, no fever, no leak on the PD side. Thus, patient was further investigated, and we are now presented with a patient with 8 years of PD use, history of recurrent PD
Okay.
peritonitis with
Dr.
organisms.
Representative, yeah,
Yes, ma'am.
was. Let's give chance to the listeners if they
Yes,
have
ma'am.
questions regarding the case before
Okay.
proceeding.
Okay.
So, do you have any questions regarding the case or the timeline of the case? So, if there is none, Dr. Perdente, kindly continue.
So for the pertinent history and the physical examination, we are presented with a case of a patient on 8 years of PD, history of recurrent PD peritonitis with organisms like Pseudomonas, Acinetobacter, and Staph aureus, now presenting with a bloody dialysate. So our differential diagnosis at this time includes recurrent PD peritonitis. TB peritonitis was also considered because it is also prevalent in our country, and history of a lymphocytic predominance in the dialysate CCDC. Fungal peritonitis was also considered when patients had previous episodes of antibiotic use due to the bacterial peritonitis. And at this time, we were also already considering beginning EPS because of the recurrent abdominal pain, history of prolonged PT, and of course, history of recurrent PD peritonitis and the presence of a bloody dialysate. Thus, I'm
Okay.
presenting the algorithm for patients presenting with bloody dialysate. So
Excuse me.
you have to,
Do
Dr.
you want
Perdente,
yes, Bob.
yes.
Yes,
anyone
sir.
to problem list the problems and also approach? If yes, so
Sorry.
do
Yes,
you
Bob.
prefer to have some our other fellow to list the problem of this case and approach uh, try to approach for the case or not, or do you want to go and continue and then finalize?
Okay. Okay. Dr.
So,
Talenset, can we ask a fellow
yeah.
or one of the audience to like give a summary of how they could have approached the case differently?
Is anyone want to volunteer to list the problem and assess a little bit?
So sorry, Katrina, maybe you could just go back one slide and then we ask
Okay.
people the approach to a investigation of a bloody dialysate. Yeah, okay, good.
Okay.
Hello, hi, Dr. Imran from Kuala Lumpur. Can I give a try?
Yeah, thank you.
So,
Please go ahead.
sorry, how old is the lady again?
53, sir.
53. Okay. So this is a lady, 53 years old lady on end-stage renal failure on peritoneal dialysis, which has been complicated with multiple episodes of PD peritonitis and dialysis vintage of about 8 years. So the last episode of bloody dialysate, I think it's good to know whether this bloody dialysate is associated with any abdomen symptom or just a discoloration of PD fluid, abdomen pains. Okay, so yeah, or any constitution symptom as well. But in terms of the differential diagnosis, the way that I will approach this case, one is related to the uh, uh, PD itself, like PD peritonitis, and also chronic PD infection like TB, tuberculosis, as mentioned before. But I also need to consider other intra-abdominal pathology like any things that like can cause infection like appendicitis or any infection in other part of the abdomens and any vascular problem. And in the female, I know she's I'm not sure whether she's still having menses or not. I think that's important to know because sometimes menses can cause bloody PD as well, or discoloration of PD. Any new medication like the anticoagulation was started outside of the PD clinic. So, and again, because of the long history of PD and recurrent PD peritonitis, EPS is also a good differential diagnosis for this lady.
Yeah, great, great.
Thank you. Yeah. Yeah. Dr. Prudente was related to what doctor has said earlier. Did you work up this patient for any other causes of peritonitis or a bloody dialysis, like other diagnostic exams to rule out TB peritonitis, fungal infection, or even did some imaging studies to rule out any other forms of pathology on the abdomen that would cause uh, bloody dialysis? So to the question of the earlier doctor, is the patient still menstruating?
Yes. So the patient mom is currently at that time menopausal, so no menses already. For the other diagnostics that we did, we ruled out fungal and TB peritonitis. Thus, we said for fungal CS and for MTB gene expert, which turned out to be negative po. For the CT scan findings, it did not show um any signs of bowel of masses or obvious cause of bowel obstruction or new abdominal mass or signs of appendicitis as mentioned prior.
Is the patient taking any medications that can cause bleeding?
No
Anticoagulants?
no medications that can cause bleeding po ma'am. Also no new medications prior to the onset of the bloody dialysis.
Okay, thank you.
Anyone else want to try or want to ask questions? Dr. Min, are you want to try?
Thank you, sir.
Yeah, okay. Please.
Is that previous like all the differential diagnosis and so I just want to ask, in case of repeated peritonitis and hemoperitonia, we should consider EPS also under the differential diagnosis. So we have to look for that.
What else do you want to investigate for this case? Besides asking for medication and the lab that show negative for TB and fungi. Anything else that you want to test or assess? If not, so maybe now Dr. Min is from Myanmar. So any volunteer from my country, from Thailand? Any fellow want to try? No. If no, so maybe Dr. Penetra, so you please go ahead.
Thank you, sir. Okay, to proceed, as mentioned, the following differential diagnoses were considered at this time: recurrent PD peritonitis, TB peritonitis, fungal peritonitis, and beginning EPS. So as we see in this algorithm, we are presented with a patient who had recent abdominal procedure, the PD catheter insertion, history of abdominal pain. So we proceeded with the evaluation of the abdomen, further evaluation. So we check for the CBC, the fluid cell count and diff count, and also did the CT scan of the abdomen, which results show that it has a loculated ascites and a thickened peritoneum. For the next step, we have checked the peripheral CBC. It did not show any significant anemia, only anemia of 89 from 85. WBC slightly elevated at 10.4, platelet at 374. For the CCDC, we have also shown shown. It to be elevated WBC at 351 with a much more elevated RBC at 2000 with neutrophilic predominance of 95 and lymphocytes of 5. The PD catheter tunnel ultrasound was done, which showed no local fluid collection. The repeat CS showed no growth, and the dialysate TB PCR turned out to be negative, dialysate KOH negative, and the fungal CS was also negative. Thus, we were highly considering at this time beginning EPS as our consideration for the case. As mentioned, the CT scan results finding showed loculated ascites and a thickened peritoneum at 0.3 cm, which is consistent with beginning EPS. So I will be showing the CT scan for this patient. This is showing the dialysis catheter tip within the fluid collection in the pelvic region. This is just the coronal and the sagittal views. Highlighted in red is the fluid collection and the site of the peritoneal catheter dialysate. Pointed by the red arrow as shown here, this is showing the thickened peritoneal lining, and also seen here are some air pockets within the fluid collection, and these findings are consistent with an EPS diagnosis by CT scan. So the initial impression for this case was a pre-encapsulating peritoneal sclerosis stage, ESRD secondary to CGN and CAPD and anemia of chronic disease. So I will proceed with the discussion po, ma'am, if okay.
Okay. Are there any questions or suggestions on further diagnostics aside from imaging study?
Actually, the thickening of the peritoneal membrane is not reported on the EPS. And PCR for TB negative, I think. TB PCR is not sensitive at all for detect TB peritonitis. So anything that you do chest X-ray from this case, or the patient have any symptoms?
Sorry, Professor.
Uh,
Obstructive. Were you asking about obstructive symptoms?
No obstructive symptoms
no,
present in the
asking about the symptom because peritoneal membrane thickening. So beside EPS, we have to differential fastidious organism infection, such as
Yes.
and PCR for TB for PD is not sensitive at all. So do you perform chest X-ray and the patient have any symptom?
Well, Dr. Prudente, was chest X-ray done also?
Chest X-ray showed minimal pleural effusion po, ma'am, but no other significant findings in the chest X-ray.
Yes.
Symptoms? Did the patient present with pulmonary tuberculosis symptoms?
Patient, no history of PTB, no history of night sweats, fever, or chronic cough that could point to a pulmonary tuberculosis diagnosis.
Yeah. Thank you. Anyone else? Yep.
Thank you, Professor. Yeah, I was just going to ask if there were any other diagnostic exams because as you mentioned, the thickening of the peritoneal membrane seen on CT scan is not diagnostic of EPS. So we need further, like the ones that were included in the algorithm was a peritoneal amylase, which was not done in this patient. And I
Yes,
would like to ask the audience if there are other diagnostic exams that we could have done to somehow strengthen the diagnosis of EPS.
Dr. Donna, I wasn't sure. Did you say something about getting a peritoneal biopsy?
Yeah. Yes. I was asking other diagnostic exams that could have like proven that it was EPS. Yes. A peritoneal biopsy could have been done, but we didn't do that. And I read in some of the literature that CA125 could also somehow uh, predict or support the diagnosis of EPS. But we still don't have that particular exam in the Philippines.
Yeah, I think the CA125 is supposed to reflect the bulk of the mesothelial cell. So in that
Yes.
case, you have mesothelial to epithelial cell, epithelial to mesenchymal cell transition. So I presume that that's the supposed mechanism of using that as a marker. But again, we don't have that
Yeah.
in Malaysia. I think it would be difficult to use. Yeah,
Okay.
I did see some papers published by the Japanese in which actually they have developed very small kind of fiber optic scopes. So the scope can go in through the PD catheter, and that scope can be used
Oh,
to obtain biopsies. There are one or
okay.
two very interesting papers have been published, and so that's a pretty non-invasive way of getting a biopsy, and apparently very good quality sort of images can be obtained by the scope, and as well as getting the pathology done.
Yeah.
Yeah.
Yeah. Yeah. Because I think that's one of the best like diagnostic tools that you can have to prove the diagnosis of diseases. Because in Philippines, we encounter like a handful of these patients presenting with bloody dialysis, but not having any other signs of infection, like no tuberculosis or TB peritonitis present as well. So we just somehow assume that we might be having EPS on the basis of the clinical history of the patient in some imaging studies. But I would also want to ask Professor and Dr. Sunita if there are other tests that you do, because in the Philippines we only have MTB gene expert to diagnose TB peritonitis. But are there other exams that you do in your country to determine TB peritonitis?
Okay. I'd like to share about uh, the the endoscopy biopsy. Push inside the PD catheter. I did once, but you need to be careful. The patient need to have straight Penkopf catheter. If you use coil catheter, so you need to strengthen of the catheter, and sometimes when the catheter strengthening, and they might penetrate or injury of the colon. So I'm not recommend you use a coil catheter. But if you use straight catheter, you can do, but biopsy through the endoscopic is quite difficult. You but you can do. You can use a spyglass, which is a ERCP, and you insert the endoscopy via the catheter. You asking about how to diagnose it, because normally EPS you need to diagnose it by rule out. You need to rule out, especially in tropical area. You need to rule out tuberculosis and fungi. For gene expert, it's not sensitive at all, at similar to PCR, but maybe more sensitive. But it's not sent for PD specimen, but it's sent for sputum. So for me, we use it's called enriched PCR, and it's quite similar sensitive as culture. Normally, the TB is the gold standard is culture, but you know that we all know that the turnaround time average is about 35 to 45 days. So sometimes it's not good because when we diagnose, the patient may not have time to treatment. So in my country, we use enriched PCR. We culture TB first, and then we perform PCR. And the sensitivity is similar to culture, but we can shortening the time to diagnose of the TB. But and also it's easy and simple to set up. Just use a regular culture media. And then after 10 days, you can use the media and perform regular PCR. I did publish in the KI report. For fungi, better to use fungal cell wall marker, which called galactomannan. Its sensitivity and specificity quite high. It's about 70%. So no matter it's a hyaline mold or not, or aspergillosis, every kind of fungi might positive galactomannan. If the galactomannan from PD fluid is a positive, so it's suggestive of fungal peritonitis. So Sunita, do you have any biomarker for EPS? Because you are expert in EPS. Or David Ross, do you have any idea want to?
Sorry, Dr. Prof. Talangsa, you're asking about what? Sorry, any biomarkers? At this point, I think there are no reliable biomarkers. I mean, people have looked at IL-6 and things like that. You can look at the PD fluid, but I don't think any of these have actually been found to be presently useful.
Beta.
Yes, yes.
Yes, to transforming growth factor beta.
Yes.
Beta. Is it okay to use that?
Sorry, Go, we can't hear you very well. You're breaking up a bit. Are you asking us whether we use beta TGF?
I will type it down.
We can't hear you very well.
Yeah, I think Dr. Sunita, he said TGF.
Yes. I mean, all these inflammatory markers, as far as I know, are not presently considered reliable enough to be used to predict EPS or to make the diagnosis of EPS.
Yeah, agree.
Yeah. Okay. Thank you, Dr. Sunita. Yeah. That's why it's also very important to rule out other potential causes of this bloody dialysate so that you can prior to really zeroing in and considering EPS. Okay. I think Dr. Prudente can continue.
To continue on, doctors,
Thank
for the discussion, this is my outline. So EPS is first described in 1980. It is a rare clinical syndrome by an acquired inflammatory fibrocollagenous membrane encasing the small intestine, resulting in symptoms of bowel obstruction. It is a syndrome of continuously, intermittently, or repeatedly presenting with symptoms of intestinal obstruction caused by adhesions of, diffusely thickened peritoneum, and it is known to be an abdominal cocoon or sclerosing encapsulating peritonitis. So for the classifications and etiologies, it is mainly divided into primary or idiopathic cause and secondary causes. The secondary causes are caused by your local systemic factors that trigger peritoneal inflammation like infection, mechanical or chemical intraperitoneal irritants, as mentioned here. Also seen here is peritoneal dialysis, as well as the presence of your endometriosis can also cause secondary EPS. Also, infection is mentioned here. So these are infection, and the history of PD is present in our patients, in our case. Tuberculosis can also cause, but as mentioned, the patient did not have any signs and symptoms of TB, as well as other causes like fungal, parasite, and organ transplant can also cause EPS, and as well as other gynecologic neoplasms. So for the ISPD guidelines and recommendations, they just presented a paper by Brown. It's a meta-analysis which shows that the risk of occurrence of EPS based on various reports in single center, in multi-center, and national registry. The prevalence of EPS has been observed to vary between zero point 0.4 and 8.9%. This is a collection of the different studies done, and its incidence rate varies between zero point 0.7 and 13.6% per 1,000 patient years. Now, this figure shows the incidence of EPS and the PD duration years. You can see that the incidence of your EPS increases in patients who have had PD for more than 10 to 12 years, and a much higher increase in those with more than 12 years on peritoneal dialysis. However, a more recent Scottish study also reported an increased incidence of EPS from 2% at early as 2.2 to 3 years and higher 8.8% at 5 to 6 years. So for our particular patient, she's already on 8th year of her PD. And also, a Japanese prospective study reported that 69% of EPS cases occurred after the discontinuation of PD therapy. So as if you can remember, this PD was put on temporary HD due to the PD peritonitis, which resulted in PD catheter removal. So this may have also been contributed to the occurrence of EPS for this particular patient. Mortality for EPS approaches 50% at 1 year after the diagnosis, and the risk factors are as follows. As mentioned, increasing PD duration is a key risk factor for the development of EPS, as well as higher dialysate glucose exposure, the use of conventional PD solutions, which have a higher glucose content, peritonitis, especially frequent episodes or prolonged, and studies would mention the following organisms: Pseudomonas, Staphylococcus aureus, and fungal and also microbacterial organisms. So younger age, abdominal surgery, beta blocker use, UF failure, higher peritoneal solute transport rate, and kidney transplantation are considered risk factors for your EPS. For the diagnosis of EPS, it is seen here that the for suspected EPS cases, it is important to check the history and to check the physical examination of the patient. Important to take note of risk factors present, which were presented earlier, and they would present with anorexia, early satiety, abdominal pain, constipation or diarrhea, nausea, and vomiting. However, aside from abdominal pain, this was not seen in our patient. If this, however, with again the history of prolonged PD, is a key factor for us to consider EPS for this patient. And the laboratories and the imaging mentioned in this algorithm is the CT scan, which shows a thickened peritoneum, peritoneal calcifications, dilated bowel loops, small bowel tethering, and loculated ascites. In our patient, the CT scan showed a thickened peritoneum and minor dilatation of the bowel loops. For the laboratories, these laboratories can only be secondary to the inflammatory process that occurs in EPS. So low albumin, elevated CRP, leukocytosis, and anemia. If we go further down to see to diagnose EPS, we could do the exploratory laparotomy for the visualization of the peritoneum, where we can see thickened brownish peritoneum or a cocoon-like bowel encapsulation, adherent loops of small bowel, and peritoneal calcifications. And again, for biopsy, what we expect to see in the histology is fibroblasts and collagen, fibrin deposition and mesothelial denudation, and neoandrogenesis and mononuclear infiltrate. This, however, was not done for this patient. This is a sample of the imaging which could be seen in patients with EPS. So the red arrows shows the thickened enhancing peritoneum. Your green arrow shows loculated fluid collection, and the yellow arrows show the tethered small bowel loops. Another image shows blue arrows shows the dilated and thick-walled loops of small bowel filled with fluid and oral contrast. The red arrows again shows the peritoneal thickening, and the green arrow shows loculated fluid collections. The yellow arrow in this picture showed bowel tethering, and the blue arrow again shows peritoneal calcification. This is just showing the enhancing thickened peritoneal lining. For the expected gross findings in patients with EPS, we could see the green arrow is the peritoneal thickening, yellow arrow points to the peritoneal inflammatory changes, the red arrow shows a calcification, and the blue arrow is the mental fat. For the biopsy, we could expect to see peritoneal thickening and fibrosis pointed by the yellow arrow and peritoneal calcification pointed by the red arrow. We could also see peritoneal thickening and fibrosis pointed by the yellow arrow. And also, for the pathogenesis of your EPS, it is still a matter of debate whether EPS is a natural progression of simple sclerosis or a completely separate entity. However, it is clear that having simple sclerosis does not predispose someone to developing EPS. It is accepted, however, that the two-hit theory presented here explains EPS development. It is well established that chronic exposure to bioincompatible dialysate causes damage to the peritoneum of all patients on PD, and this is the first hit that causes mesothelial disruption, which can trigger a fibrotic process, which is referred to as simple sclerosis. The subsequent exposure to a second insult in some patients triggers the development of EPS. So this second insult can be episodes of peritonitis, acute cessation of PD, transplant, or any intra-abdominal event, or may be a genetic predisposition. So, so we have the EPS staging system, which has been proposed in the PD-associated EPS literature. We can see here the stage 1, it is the pre-EPS stage. There would be loss of ultrafiltration capacity, development of high transport, hypoproteinemia, bloody dialysate, ascites, calcifications in the peritoneum. This is usually termed as pre-stage, and the clinical findings include abdominal symptoms, mild inflammation, and mild encapsulation, or can have no clinical findings at all. Stage 2 includes inflammation stage. This time you can see since inflammation stage, this time, since as mentioned the term inflammation, there's already increased CRP, leukocytosis, fever, chills, weight loss, anorexia, diarrhea, and ascites. So the abdominal symptoms would include nausea, diarrhea, and can lead to mild to severe encapsulation. The stage 3, this is the encapsulating stage. There is decrease in clinical signs of systemic inflammation. However, there will be early signs of ill use like abdominal pain, nausea, and vomiting. This is termed as encapsulating, and the symptoms would include periodic ileus and mild encapsulation. The stage 4 is the stage. Patients would present with anorexia and complete ileus and would present with an abdominal mass. And this is considered a chronic stage. And the symptoms would include persistent ileus, and inflammation may be, no inflammation may be seen, and only mild encapsulation present. So for our patient, she is in the pre-EPS stage. So we have the diagnosis of pre-encapsulating peritoneal sclerosis stage, ESRD, secondary to CGN and CAPD, and anemia of chronic disease. For the EPS management, the discontinuation of PD, in some cases, they are clinically less severe and could potentially worsen if you stop PD. So for mild cases, they don't recommend shifting to HD from PD. Again, supportive therapy is also advised with aggressive nutritional support since this patient is usually hypoalbuminuric and malnourished. For the medical therapy, corticosteroids, tamoxifen, and immunosuppressant are the medical therapy options, and surgical intervention is only indicated if there is partial gut obstruction and for partial and complete enterolysis. Again, it is important to note that the switch to HD, if high risk of PD technique failure, there could be, this includes the high risk for technique failure would include high and rising peritoneal permeability, low UF capacity, difficulty in fluid balance control, and requirement for high glucose dialysate. So if you have this present, you can opt to shift your patient to HD. But if none of those are present, it's still advisable to maintain them on PD. Now, in all the stages of your EPS, the cause should be identified or treated. So if you have peritonitis, it should be treated. If you have any medications that can cause EPS, it should be withdrawn. And if necessary, as mentioned with the previous factors below, PD can be shifted to HD. However, in the later stages 3 to 4, where advanced sclerosis may be present, patients may start exhibiting signs and symptoms of partial or complete bowel obstruction, thus may need surgical intervention and aggressive nutritional support. The mentioned treatment here is corticosteroids, tamoxifen, and surgery is the last if no response to medical therapy. For the short discussion on the medical therapies available, tamoxifen, the starting dose recommended is 20 milligrams BID. You have to observe for the clinical response within 1 to 6 months, and it should be continued for at least a year and then tapered off. And it is a selective estrogen receptor modulator that inhibits the production of your TGF-beta by fibroblasts. And glucocorticoids is also used. If without infection, you could opt to do pulsing with MPPT 500 to 1,000 for 2 to 3 days, and or prednisolone at 0.5 to 1 milligram per kilogram per day for 1 month and taper off over a year. And uh, yes. Other therapies include azathioprine and mycophenolate, but they are still not in the recommendations and are still mostly in trials. Human data suggests that tamoxifen and steroids might be useful in the prevention and or treatment of EPS. However, data on ASA and MMF are scarce and are weak as of this time. Other experimental data includes rosiglitazone, NAC, colchicine, your RAS blocker, thalidomide, everolimus, and biocompatible PD solutions. These are solutions which has a lower osmotic agent or alternative osmotic agent other than glucose. So another recent animal data with rosiglitazone and colchicine, blockade, thalidomide, and everolimus are promising. However, in the absence of further studies, it was difficult to support their use in EPS. So for this patient, plan to start on tamoxifen 20 milligrams once the fungal CS and repeat dialysate CS are negative, and continue the CAPD following prescription, monitoring for the response. So monitor CT scan we monitored for the CT scan every 6 months, and monitor patient for any signs of obstruction um, or worsening of abdominal pain, or also failure of her PD, of her peritoneal dialysis, and supportive care like nutrition and hygiene, and to prevention of further episodes of peritonitis. For renal transplant and EPS, there is no evidence on the genuine sustained increase in the occurrence of post-transplant EPS. And the resolution of established EPS following renal transplant, transplant as a result of immunosuppression. And EPS can also occur after transplant in patients who have been exposed to PD for several years. And ideally, patients should be transplanted within 3 to 4 years of starting PD. Again, for prevention, minimize dialysate glucose exposure, prescription of biocompatible PD fluids, prevent acute PD-related peritonitis. And the most long-term patients will not develop the complications, and it remains to be a rare entity, and mandatory transition of PD after a predetermined interval does not seem justified. And so the diagnosis requires a high index of clinical suspicion from clinical manifestations, constellation of CT or pathologic findings consistent with EPS. Because as mentioned by all of you, no gold standard diagnostic laboratory or imaging is available for EPS. So it requires a high index of clinical suspicion um, with correlation of the history, risk factors, and clinical presentation, as well as the imaging findings. There is also no evidence to hold PD only to prevent EPS, and there is no optimal time for PD duration to avoid EPS. And long-term patients should be counseled regarding the risk and benefits of remaining on PD or attempting in-center hemodialysis, and shared decisions should be made with the patient. For the treatment, it is again not standardized, but it focuses mainly on aggressive nutritional support, medical therapy with tamoxifen and steroid, or surgery in select cases. And PDRS is again controversial because it can also increase the risk for EPS, and it is not a contraindication to kidney transplant. So my references. Thank you, everyone.
Thank you, Dr. Prudente. Are there any other questions from the audience?
So the patient continues PD, right? So the
Sorry.
patient is still on PD right now, right?
No. Dr. Prudente, how is the patient now?
The patient, unfortunately, the patient had another episode of PD peritonitis last July, and was shifted to HD, and is currently on HD 3 times a week, with currently no plans of returning to PD.
Okay, good. Do you have any PET result for this case before transfer the patient to HD? Do you perform PET test?
Sorry,
Sorry.
Professor.
Any
PET.
chance to perform test?
I think he's asking about the PET test, Dr. Katrina.
Yes, the PET test was done in 2019. She was a high transporter. No repeat test. PET test was done after.
So how many of sodium victims get people? What is the result design of a high transporter or fast transporter? Approximately my
Can you come again?
Dr. Talangsat, we can't hear you very well. Maybe you could type it in the chat. The question that you have. Katrina, I want to say thank you very much, but maybe, you presented earlier that the mortality was up to 50%, but I think that was from the really old studies, like in the PANTAM study, etc. And I'm wondering whether, with the more recent surgical expertise and change in the way that we manage more aggressively the nutrition of the patients, I think that perhaps it's not quite so dismal, I mean, not so depressing an outlook for the patients with EPS. But again, I think just to stress that probably what's really needed is multidisciplinary inputs, early diagnosis, and perhaps management by a team with experience, because it's such a rare disorder.
Yes.
So it probably helps to, have shared experience, or to have a team that has had this sort of like become a referral site to manage EPS cases. So I'm not sure whether in the Philippines, if there are EPS cases, do they get sent to your NKTI from everywhere else? Because in UK, that's what they do. They send them all to Cambridge and Manchester. And I think they do the same thing in Germany. In Malaysia, we don't really have particular centers of excellence, but we do have a surgical center that has done quite a bit of this kind of bowel surgery.
In the Philippines, NKTI holds the largest PD center. We see EBS cases most of the time, but regarding the referrals from other institutions, they're usually not referred to our institution, most probably because they're handled by private nephrologists.
Okay.
Yeah, I just want to add on to the thing. For this case, right? I'm just wondering. For the EPS, usually important is prevention, early prevention. So you mentioned about the case, right? At the beginning, I'm just wondering, what is the initial PD prescription for this patient, right? Usually we try to minimize the exposure to the high tonicity glucose. So I saw at the end you're giving 4.25 dextrose tonicity. So maybe at initial year, one patient was at the beginning of the peritoneal dialysis, it might be try to spare the glucose at the beginning when they still have the residual kidney function. In this way, at least to minimize the glucose exposure eventually. And second question is, I'm not sure the Philippines you do have the compatible solution or not, like angodestrine or neutral pH low GTP solution. If of course if there's available, then it's good to choose this type of solution that will probably a little bit more familiar for a little bit more better for the membrane, because we know that bioincompatible solution tend to cause a membrane injury more than the biocompatible solution, because they are acidic solution, hyperosmolar, and also got GTP inside the PD solution, right? Yeah, eventually the third one is he has a frequent peritonitis, and I also noted that there's one episode he has a TK insertion. After 3 days, he got the PD peritonitis again. It's kind of like considered the PD catheter insertion related peritonitis. I wonder what are your center give prophylaxis antibiotic before catheter insertion? Yeah, so at least try to prevent frequent peritonitis. Yeah, so to prevent the EPS. And finally, for the EPS, usually a diagnosis is based on the clinical feature and also and supported by the CD finding. So far, there's no reliable biomarker to do. Other thing that people mention about the peritoneal equilibration test, but this patient already high at the beginning, right? So it's already high. So basically, we from our side in Singapore, we based on the clinical feature and also the CT finding together. So usually have a high index of suspicion, especially for those patients. They are on the PD for many years, like PD vintage is high. We will try to keep an eye on that, whether they have a GI symptoms or not. So in your case, patients, I believe, now converted to the hemodialysis already, right?
Yes, ma'am.
Yeah, so I think you studied the tamoxifen for the patient and also the steroid. I think it's okay, but you also need to monitor the side effect of the tamoxifen, especially the woman. Yeah, because
Yes.
gynecological malignancy is also an important thing to look out for. And usually, what I will sometimes do monitor is for this group of patients, when we start the steroid, right, you might want to train the CRP to see whether it's respond or not. Usually, CRP will come down. Patient nutritional status should be improved, like hemoglobin, albumin should be going up if they show some response to your therapy.
Yes.
Yeah, back to you.
Noted po, ma'am.
Thank you.
Regarding the icotrokinra, ma'am, it is available, ma'am, but it's on an out-pocket basis. But I think PhilHealth is working towards giving it as part of the government subsidy PD solutions po, ma'am. It's available right now, but it's more expensive than the glucose-containing PD solutions.
Understand? Yeah. Okay. Yeah, because your patient mostly on the CAPD, so I think yeah, if financially it's not a constraint, then if you can get the angiotensin a little bit early, it's good for them instead of studying on the 4.25% testo solution.
Yes, ma'am.
Thank you, Dr. Tete. I'm not sure, do you hearing me well or not?
Better now.
We
Better now.
can, yeah.
Okay. So big thank to Dr. Donna and Dr. Katrina for preparing such a engaging, insightful case, and to all of you. And I think I will leave it for Sunita to close the session. But last but not least, I think I encouraging you to participate in the incremental survey initiated by Dr. Jane and his team from Canada and Australia. The QR code is attached in the chat box, and your response will help improve PD quality worldwide. So I'm gonna hand it over to Sunita to close the session.
Okay, I'd just like to echo our thanks to Dr. Donna and Dr. Katrina for a very nice case presentation today. And in case you do not manage to download and get the link to Dr. Talangsak's survey, we will post it also on the ISN OSEA WhatsApp group. Is that right, Talangsak?
Yeah. We do both in ISN OSEA and ISPD APC as well.
Okay, as a place that we can then give you the responses to the survey. So once again, happy Chinese New Year to all who are celebrating, and thank you for joining us today. Bye-bye.
And
Thank
see
you
you
very
on
much. Thank you.
the end 2025, and next time gonna be March 25, March 25th for Singapore. Dr. Jason gonna volunteer for GN cases.
Thank you
Okay,
very
great.
much.
Thank
Thank
you.
you. Have a great
Bye-bye.
day. Bye bye, Sarita and everyone.
Bye.
Thank you.